Doing well. And this morning I'm going to be talking about chest tubes. Gonna wait a second here and check to see. Y'all know there's a 20-second lag. So just checking to make sure that we're on. All right, so let's share the screen. And we're going to go here. Here we go, chest tubes. Hopefully you have some idea of chest tubes. We're going to talk specifically about the function and the things that we need to know as far as nursing interventions. Okay, so here we go. So what does a chest tube do? Chest tube's function is to return the negative pressure to the interpleural space. Interpleural space is the space between the two pleural surfaces. They rub together normally, and there is negative pressure between those normally. What causes the negative pressure to be lost is air from an actual penetration into the lung cavity, or trauma that has caused blood to go in, okay? So it removes the air and fluid from that space. Okay, there are three chambers to a chest tube. The first one is the suction chamber, and it's this far one over here. I hope you can see my cursor. It's over here on the side. It's the one that has suction going into it, and I would expect, we're going to talk here in a minute about what we would expect in there. The next is the underwater seal, which is this chamber down here. And then lastly, we have the drainage chamber where all the drainage goes. So now the suction is where the suction is. And so in that area, I would see bubbling if it is to suction. Bubbling should be continuous there. And that's what helps provide that negative pressure. The underwater seal, this is where the tip of the catheter is underwater, and that helps bring that negative pressure. If the chest tube itself isn't there, the lung will collapse if it's not healed, okay? The underwater seal area, I only should see intermittent bubbling. If I have a pneumothorax and it's resolving, the air has to come out into the water there, but it's intermittent. I should never see continuous bubbling. If I do, that is a sign that they have a leak somewhere in the system, either from the drainage, the drainage container itself, all the way in to the patient, okay? Then the drainage chamber is where the drainage collects. The amount is checked and recorded as the MD prescribes, and that can be every shift, but you're going to be marking on the container itself every 1 to 4 hour periods, depending on what the doc wants. After a surgery or after it's initially put in, we should not see more than 70 to 100 mils of drainage. And I should be very aware if it's bright red drainage and let the doctor know that. Okay, So nursing interventions. What do I need to do for this patient that has a chest tube? I need to assess their respiratory status. Are they breathing easy? Are they struggling? Are they using accessory muscles? And then their lung sounds. What can I hear? Can I hear lung sounds in bilaterally? Okay. Then I need to keep the drainage system below the level of the chest. So on the bed, that means it either needs to be on the floor next to the bed or attached to the bed frame itself. If they're going by stretcher, it just needs to be attached so that it's below the chest. The tubes, they need to be kept free of kinks and no dependent loops on them. I need to encourage coughing and deep breathing to help bring out any of the mucus that is in the lung, and it is also to help just with respiratory, the respiratory system reestablishing itself. I should never milk the tube, and milking the tube, ladies and gentlemen, is where I take something and I rub down it and I literally push and pull fluid out of the chest. We never clamp it unless the doctor gives us a prescription. And then if the system breaks or comes apart, I need to insert the end of the chest tube itself into a sterile bottle of normal saline. That will reestablish that negative pressure and they'll be able to breathe. And the last thing, and it's not on the slide here, is if the doctor is coming in to remove that chest tube, we need to have instructed the patient to do the Valsalva maneuver. We don't want them inhaling or exhaling while that tube is coming out. So we have them take a deep breath and bear down like they're going to have a BM, okay? And that will help with that. Okay, so this is just a quick review, not as long as some of my others, but it's a quick review of what we need to do for chest tubes. And I know a lot of students have had issues with chest tubes here in the office and online. So, just so in case you haven't seen it yet, yes, coming soon, a book by me, and will be available on Amazon soon. I'm wanting you to pay attention. There is a link here in One-on-One NCLEX's Facebook page to my actual page for the book, and that will give you the alerts as to when I do the virtual book signing. And you'll want to be watching that because we are going to have some surprises on there that might be of interest to you. And then lastly, our team consists of Courtney, my assistant, and of course, me, and the big part of our team is you. We can't do it without you. So, just so you know, just want to say thanks. And if you have any questions, please get a hold of us here at One-on-One NCLEX Tutoring, and you can do that by emailing me at Rhoda Sommer at oneononenCLEXtutoring.com. It's been great talking to you. I hope you have a great day. Bye-bye.